Hello and welcome to WVU Medicine Tuesday Talks. I'm your host, Mary Ravazio Menard. With obesity rates on the rise, an estimated 250,000 people underwent weight loss surgery last year in the U.S. Recently, two national groups of bariatric surgeons overhauled the weight loss surgery guidelines for the first time in more than 30 years. The updated guidelines mean more people are eligible for weight loss surgery. So who's a good candidate for weight loss surgery? And what are the surgical options? We'll answer those questions and more as we're talking with Dr. Salim Abunnaja, bariatric surgeon with the WVU Medicine Medical and Surgical Weight Loss Center. Welcome, Dr. Abunnaja, to Tuesday Talks.
Glad to be here. Thank you for having me.
It's good to have you. We encourage you to post any weight loss surgery questions you may have in the comments section below, and we'll try to answer them live. Okay, so this is a widespread problem. So let's just start with the basics first. Can you talk to us about obesity and its health impacts?
Absolutely. So, obesity there's a lot of misconceptions when it comes to obesity. It's one of those health conditions where there's a lot of myths and a lot of people have a lot of misconceptions and misunderstandings about it. And I think it's important to define things the way they are. Obesity is a disease. And it's a chronic disease. When we say chronic, it means very difficult to treat, and it takes, sometimes it might be a lifelong treatments that patients may require when they have obesity. There's a lot of relapses, meaning patients may be successful in losing some weight, but then often they may gain some of that weight back. And that's why, and it also affects our body in so many different ways. That includes metabolic things like diabetes and high blood pressure and high cholesterol and heart disease and so forth. It also has a significant mechanical, and biomechanical effect to our bodies. Things like sleep apnea, arthritis, back pain, and so forth. And let's not forget the psychosocial impact of obesity that many of our patients will have some of those problems too, such as loss of self-esteem, depression, and so forth. Unless we understand the problem and we deal with obesity as a disease, we're going to have a difficult time treating it. In other words, many people think of obesity as a lifestyle choice, meaning people that perhaps eat too much and not exercise enough, which is obviously not true.
It is a disease.
It is, and also a chronic disease. I often describe obesity the same way we describe cancer, meaning it's a disease, it's very hard to treat. There's actually classification of obesity. So if we look at obesity, how can we measure obesity? There's so many different ways. We often look at weight only. Mm-hmm. There's an equation called the body mass index where we look at weight and height, and that is a little better than just looking at the weight. And based on the body mass index, you can actually classify the obesity, the severity of obesity. So for example, if someone's a normal or an ideal body weight is a BMI between 18 and 25. And that's when you look at someone perhaps today and you think of as skinny, that's usually someone who has an ideal body weight. A BMI between 25 to 30 is what we call overweight. And it's actually the majority of people in this country. So about 70% of the population has overweight. Mm-hmm. And then anywhere between 30 to 35 is what we call class 1 obesity, similar to what you say stage 1 cancer. And then 35 to 40 is what we call class 2 obesity. Anything above 40 is what we call class 3 obesity, and that's kind of at the advanced level of obesity. The reality is we treat patients with much more severe disease today than we've had years ago. We see patients with a BMI of 70 and 75 and 80 and even 100 in our clinic. So the severity of the disease also dictate what kind of treatments and so forth.
Okay. So why is it so hard to lose weight?
Yeah, I think that's the most important question I think to discuss. Why is it so hard to lose weight, and why many, if not all, those fad diets that people try every day will eventually not be successful or fail. Losing a few pounds here and there is not what we're talking about. Pretty much most of us are able of losing some weight when we perhaps change some of our dietary habits and embark on a healthier lifestyle. That is not what we're discussing here, and that's, but what we're talking about is losing significant amount of weight, transforming someone with a BMI, let's say, of 50 or 55 or 60 to a normal BMI, and meaning losing 100, 150, 200 pounds, 250 pounds of weight loss, and sustaining that weight loss for long term is extremely difficult. The reason is we don't have much control over that. It's not a matter of willpower. Think of your body temperature. Your body has a center in your brain that controls your temperature. So if your temperature goes down, it tries to bring it up. If your temperature goes up, it tries to bring it down. So we have something called the feeding center. It's in our brain, a part called the hypothalamus, that regulates our satiety, it regulates our hunger level, it regulates our metabolic rate, how much calories we burn. If you look at history, humans have survived for thousands of years through famines, through scarcity of food, through difficult times, and food wasn't always available. So we had to evolve in a way to maintain and hold on to body fat because that was a survival thing.
Was survival.
You may find a meal today because you were hunting or you were gathering, but you may not find a meal for 2 or 3 days from now. And that's why holding on to body fat was a survival mechanism. Today,
we don't have that problem.
Things are different. We have abundance of food. Our food is highly processed and so forth. So we do have too much, convincing our body basically to undo all those years of learning to hold on to body fat and convincing our body to know it's not a good idea, let's start to lose that body fat is not as easy as we think it is.
So then how can you effectively treat obesity if, it sounds like you're fighting your body?
Correct. Mm-hmm. And I think that is I think the most important thing to discuss. How can we effectively treat obesity? It depends on the disease. It depends on the patient.
Okay.
Trying to have one fix for everyone is, I think, where most people or most even providers are not looking at the right way. When you say diet and exercise failed, then you can have surgery. I don't think that's the right approach. We should say, well, does the patient, how severe is the obesity? Are they in the overweight range? Are they in the level 1 or class 1 obesity? Do they have class 2 obesity? Is it realistic to ask someone to lose 250 pounds by only eating healthy and exercising? It might be realistic for someone who has an additional 20 pounds of weight that they need to lose, but it may not be realistic for someone who has 250 pounds weight. So I think it has to be an individualized care based on the patient, based on their disease, based on the severity of the disease. What other health problems do they have with obesity? Are they young? Are they old? And there are a lot of things that play into it. So this is what we call a multi-modality approach. Okay. And I think this is what...
No one size fits all.
Correct. And I think there are basic things that pretty much most, not just patients with obesity, everybody should be doing, eating healthy and exercising, and that's not dieting. Dieting is a completely different thing. Eating healthy, meaning what your grandma probably taught you, vegetables and fruits, and avoiding processed food and incorporating more and more plants in our diets and being physically active is what everybody should be doing. That's not necessarily just patients with obesity.
Right.
But that, again, will help us maintain our weight, help us live longer, help us stay healthy, and maybe help us lose a little bit amount of weight. But it's not going to necessarily help that patient lose 200 pounds, if that makes sense.
Yeah.
So that is a given, but then based on that, we start building. So if someone have a BMI of 30 to 35 is what we call class 1 obesity, perhaps that patient may qualify to some medical weight loss assistance with medications. If their BMI goes above 35, which you were referring to earlier, the guidelines that got introduced recently, those sort of guidelines have changed after 30 years of struggle and battle to try to change those guidelines.
Yeah.
Basically, any patients who have a BMI more than 35 fit in what we call a class 2 obesity should qualify for bariatric surgery. And if they have class 3 obesity, even more reason. Even if they have only class 1 obesity, but they have, for example, poorly controlled diabetes, they should qualify for bariatric surgery. And one last thing I want to say about that, we often hear the word metabolic surgery too. So it's not just called bariatric surgery, it's called bariatric and metabolic surgery.
Oh, okay.
And metabolic means it's an operation that cures the metabolic syndrome like diabetes and high cholesterolemia and hypercholesterolemia and so forth. So patients who have even lower BMI, a BMI of 30, who have severe diabetes may also qualify for bariatric surgery, what we refer to as metabolic surgery.
So how can bariatric surgery help patients with obesity? And who's a good candidate for bariatric surgery?
So kind of completing where we stopped, I think the severity of the obesity is something we have to look into. So we are not going to offer bariatric surgery for a patient who has, overweight only, or have class 1 obesity but don't have significant metabolic burden like diabetes. But as patients, once you get to the BMI of 35, and that's the guidelines refer to, which is a class 2 obesity or a more severe level of obesity, then those are the patients that can benefit from bariatric surgery. And I think it's good to point out here, we often hear the term that bariatric surgery is the last resort. And I think we have to stop saying that to patients.
Oh, okay.
Because I think that's not the right terminology. If you have, for example, a patient who has, other diseases, like let's say cancer, you want to treat that disease as early as possible. You don't ask them to wait till they have stage 4 cancer and then try to treat it. And, you want to treat them as early as possible, as effective as possible.
That's an interesting analogy.
Yeah, and that's why if the patient has severe enough obesity and their BMI level meet the criteria and they don't have contraindications for surgery, I think that will be a patient I will highly encourage to kind of at least get the consultation and understand what this is about, instead of saying, well, how about you try this, and how about try that, how about try this, and then 4 or 5 years down the line refer them back surgery after they quote unquote failed everything and developed diabetes and so forth. So the earlier you treat the disease, the better the outcomes.
The better the outcome.
Correct.
And I've heard that bariatric surgery can actually cure diabetes.
Correct. I think.
Is that an instant thing?
It is actually an instant thing, yes.
Wow.
For many patients, of course. It depends on the severity of the diabetes. But bariatric surgery is the most effective, we call it metabolic surgery again, the most effective way to treat diabetes. I can't tell you how many patients I've had who come to the hospital, have their bariatric surgery today, and they go home off their insulin the next day. They haven't even lost the weight yet.
Wow.
We just tell them to monitor their blood sugar at home and then use a sliding scale if they need insulin. And that's so many patients. And then
that's amazing.
The word cure, some people have, stand against the word cure. It's like, oh yeah, you can't cure it, it may come back. Well, we sometimes refer to it as long-term remission. So we've had studies showing that bariatric surgery may have up to 10 years after bariatric surgery have, remain free of all their medications from diabetes. And to me, I call that a cure. But again, if you don't want to call it cure, you can call it long-term remission, which is meaning patients get off all their diabetes medications. They have a normal A1C, normal blood sugar, without taking any medications. Yes.
Okay. And of course, there's not just one kind of weight loss surgery. There's more than one kind. So tell us about what the options are.
Correct. And that's, again, back to what we said, that one size fit all is not what we're looking at. And that's important. And it's also important to point out that where you go to have your bariatric surgery is important too. Bariatric surgery should be done by surgeons who are trained to do bariatric surgery. And they can offer a broad spectrum in a variety of operations that will fit the individual and not just tailor to what the surgeon is capable of doing, if that makes sense.
Is there like a board certification?
There's not a board certification, but there is fellowship training for bariatric surgery, and then there's a certain requirements that you have to meet to get the American Society of Metabolic and Bariatric Surgery certification.
Okay.
The most common operation that you will probably hear is an operation called the sleeve gastrectomy, which is an operation that involves removing a big portion of your stomach, including part of the stomach called the fundus, that plays a role in our hunger and satiety. There's also, you probably heard of what we call a gastric bypass or Roux-en-Y gastric bypass. I'll say these two operations are the most commonly performed operations today in the U.S. There's an operation called the duodenal switch, which is an operation that's a much more aggressive in terms of weight loss. It is usually reserved for patients with very, very high level of obesity. We're talking about patients with a BMI of 65 and 70 and 75 and so forth. So it's a much more advanced operation, or stronger operation that could be offered to some patients, but it's also more technically demanding, so it requires surgeons to have a special training in doing these operations. And then you may hear in the next few years about other operations that have been approved by the American Society of Metabolic Bariatric Surgery, something called the single anastomosis gastric bypass and the single anastomosis duodenal switch. And these are other operations that are, I think, very, very promising operations, yet the insurance coverage is still not available for many of these. But I think since the American Society of Metabolic Surgery have endorsed these operations, I think that may change in the
That's
next few years.
coming?
Yeah, that will be coming.
Okay,
Yeah.
that's good.
And yeah, so we need to tailor the operation to the specific patient. And this I can take a long time talking about the operations, but in brief, just some examples. If someone has obesity and has significant acid reflux, or what
Yeah.
we call GERD, that may not be a good surgeon, a good patient or candidate for a sleeve gastrectomy. That might be a good candidate for a gastric bypass.
Oh, I see.
If a patient has severe arthritis and they take a lot of pain medications like Advil, Aleve, ibuprofen, naproxen, they may not be a good candidate for a gastric bypass. That patient may be a good candidate for a sleeve gastrectomy.
Oh, okay.
If a patient has severe diabetes, then the bypass might be a better operation than a sleeve gastrectomy, and so forth. So there's a lot of tailoring that we do, and we try to find the right fit, the right operation for the right patient.
Again, one size does not fit all.
Yep,
Right.
absolutely.
Okay, now I think this is a common question among most people. Is weight loss surgery safe?
That's a great question. The simple answer is yes.
Okay.
So there's nothing that we do in medical care that's risk-free. Even the medications that we take on a daily basis, they have a long list of side effects and so forth. The bariatric surgery safety has come a long way from the early times in the 80s and the 90s and so forth. Everything we do today is minimally invasive, meaning laparoscopic. We use small incisions, so patients will have a much smoother recovery. We don't have to cut, with a big incision. We do so much workup and preparation before surgery. So almost all of our patients will get an echocardiogram to assess their heart. We'll have a sleep study to check them for sleep apnea. If they have diabetes, we'll make sure their diabetes is optimized. If they're smoking, it's a requirement they quit smoking. They work with our dietitians before surgery. So there's a lot of preparation that goes into the operation in preparing the patients themselves. Of course, I have to claim that we as bariatric surgeons think we're very talented and very good at what we're doing. So I think that's important too, that the surgeon is trained in what they're doing. But also we have a trained staff from anesthesiologists and nursing staff and so forth that take care of the patients. So just to put things in perspective, if you look at what we call a 30-day mortality, which is the chance of someone dying from the operation, the chance of someone dying from an operation like a sleeve gastrectomy within the 30-day from having an operation is less than 1 in 1,000. And to put things in perspective, you compare that to a common operation like a gallbladder surgery.
Yeah.
That's about 5 to 10 in 1,000 rate of death from a gallbladder surgery. An appendix is about 5 in 1,000.
That gives a good perspective.
Good perspective. An open heart surgery is about 2%, so 2 in 100.
Wow.
So you can see so that gives you an idea of the safety of the operation. But we understand how the operation can be a little bit intimidating to the patient. One last thing on that, which is very important to talk about, is we worry about the risk of the operation, but we underestimate the risk of obesity itself. If the patient has obesity and diabetes and high blood pressure and high cholesterol and so forth, they are actually at a much higher risk from dying prematurely or dying young and having so many health problems, much higher than the risk of them having the operation, if that makes sense.
Yeah. Risk benefit, right?
Correct.
Okay.
And I think in this situation, the risk benefit is clear toward having surgery. Otherwise, we won't be doing the operations.
Yeah. So if you do have weight loss surgery, how long is the average hospital stay, and when do I get to go back to work, right?
Yeah, that's a great question. So I kind of touched on that earlier when I said we do laparoscopic or minimally invasive surgery. That could be laparoscopic or robotic, and those are the small incisions. So the average stay for almost all of our patients is 1 night hospital stay.
That's
so
it?
You have surgery Monday. Yeah, we have surgery Monday, for example. Like I just came from the hospital rounding on patients. I did surgeries yesterday. They go home today. So it's a 1 night hospital stay for the majority of our patients. A very small percentage of patients who live locally around the hospital here in Morgantown, who are young and don't have many medical problems, we do same-day surgery. We do surgery in the morning and they go home, let's say we do surgery at 7 in the morning and they go home around 4 p.m. or 5 p.m. And they come next morning to be checked in the office. So we do same-day surgery. But for the majority of our patients, it's a 1 night hospital stay. Every now and then there will be a patient that lives 3-4 hours away and may not be comfortable going home the next day, so we'll keep them an extra night. But usually it's a 1 night hospital stay or a same day.
Okay.
In terms of going back to work, It depends on what kind of work they do. I'll say that 2 weeks is an average for most people.
Okay.
I've had students go back to school within a week.
Wow.
And we've had people may stay out work for 3 or 4 weeks if they do like construction work or a lot of
Yeah.
manual work. But for the average office kind of a job for most of our patients is around that 2 weeks window where they can go comfortably back to their work.
Okay. I think another common question is, can you eat anything you want after you have weight loss surgery?
And the answer for that is actually yes. So the question is, should you be eating everything you want? And I always, when patients ask me about that, I tell them that I don't think that bariatric patients need to eat differently because they had bariatric surgery. I think bariatric patients need to eat differently because all of us should be eating differently. I think our society, our standard American diet is very unhealthy. It is the reason why we have diabetes and high blood pressure and obesity and so forth. So I think what we want our bariatric patients and anyone who comes for advice is to slowly switch away from that and replacing, for example, the soda with the water, replacing, you know, the desserts and the sweets with the fruits, you know, and so forth. But that does not mean a bariatric patient cannot go out, you know, with their family on a weekend and have a dinner at a restaurant or have a Thanksgiving dinner with their family. I just think it's what we do every day that makes the big difference. It's not that occasional event. So the answer is yes, they can eat whatever they want in terms of, and we're of course talking about once they recover, a year after surgery, 6 months, not immediately after surgery. But yeah, in terms of what they can handle, most bariatric patients can handle anything. The portions obviously could be smaller and so forth, but we obviously want to hope that they will make significant changes to help with that long-term, you know, outcomes.
Okay. We have a question from a viewer, and the question is, what is recovery like for the gastric bypass surgery versus the sleeve procedure?
It's exactly the same, meaning that we do the one-night hospital stay. We have not yet done same-day bypasses, even though I know some programs have done that. So meaning we expect the same recovery. You go back to work the same, you know, amount of time. We give the patients the same advice when they go home. They're going to use the same multivitamins. It's exactly the same process. You know, when we do the operation, the gastric bypass is a more involved operation, so it takes a little longer time. You know, let's say on average it takes me about 2 hours to do a gastric bypass, maybe an hour to do the sleeve gastrectomy, but we don't expect a different recovery for the patients.
Okay, so that's one thing that's similar. Okay. Do you have any figures on the success rate of weight loss surgery?
Yeah,
and is it possible to gain the weight back after the
absolutely.
surgery?
That's a great question. I always like to talk about this subject. You know, so I think the terminology of success and failure needs to change. You know, that terminology of success. What is the definition of success? Is it the amount of weight the patient's lost? So the patient that was able to lose enough weight to get their knee replaced and they can walk normally now, is that not a success, even if they have not lost as much weight as someone else in terms of weight? Is it getting off the diabetes medications? You know, that's the success. Is it, you know, being able to play with your grandkids and be able to, you know, keep up with them when you walk outside? That's success. So it's not necessarily just that if you lose 100 pounds, you've succeeded the operation. If you lost 80 pounds, you have not. And also, let's not forget that the severity of the disease starts differently. So for a patient, some patient, maybe 100 pounds may not be enough. For other patient, 50 pounds is more than enough. So I think that's important to underline that there's not really a specific number where we define success and failure. I don't think overall that there's any failures with this operation because most patients will get something out of the operation. In terms of weight regain, we have to understand, like we discussed earlier, obesity is a chronic disease. A patient that perhaps loses 200 pounds and maybe 10 years later they gain 50 pounds back or 100 pounds back has not failed anything. That is the nature of the disease. The body is going to fight back the weight loss.
It is a disease.
Yeah, we call that metabolic adaptation. The body is going to adapt to your new anatomy. It's going to try to push back the weight on you. And even though patients have had a great operation, even though they've been compliant, even though they've been following up, they may gain some weight back. Of course, we want to aim for the best outcomes in terms of doing the best possible operation. We want our patients to do their best in terms of, again, making sustainable, healthy choices when they're eating and being physically active and so forth. But we understand that obesity is a chronic disease, and that's when the multimodality approach helps. That's when I have many of my patients that maybe years later can be placed on weight loss medications to help them lose some of the weight, the weight regain
they came back.
and so forth. And then, of
And there's
course,
nothing wrong with getting that kind of help, right?
absolutely not. One thing that's very different from bariatric surgeons than other surgeons is the kind of relationship we have with our patients. It's a long-term relationship. Usually surgeons will, let's say, take an appendix out, they will never see the patient again, maybe once in the office, but we see them for life. We take care of them for a long time. I see patients that I've done surgery on them 5 years ago or 4 years ago or 6 years ago, and we'll see it's always nice to catch up and see them, and we provide them with annual visits. So they come every year to be checked. We check their vitamin levels. We look at their weights. If we see any deviation from their weights, we help them with medications and things like that. So it's a long-term care that we always tell our patients, think of us as your second primary care doctor.
So there's support before, during, and after.
Absolutely.
For the rest of your life.
Correct. And that support, there's a minimal support that everyone is going to get, but then specific patients may require a little more support, and we provide them that individual support if they need.
Okay. Now we got to talk a little bit about cost. Do insurance companies usually cover weight loss surgery?
Correct. So most insurance companies, I can't say all, most insurance companies today cover bariatric surgery. There are different requirements for some insurance companies than others. Some may make it a little harder, some may make it a little easier. But the trend overall is for insurance companies to cover more and more bariatric surgery. Because even from a financial aspect, it is better for them to cover these operations because they realize by covering an operation, the insurance company may be paying an upfront cost, but then that patient is not going to use their insulin anymore. They're not going to use this. So they're saving costs on the long term. So many insurance companies are moving toward more and more coverage to bariatric surgery. I wish I can say 100% of insurance companies will cover bariatric surgery. That is something that's not true. So you got to have to look into your insurance coverage and see if bariatric surgery covers it or not.
And now that they've recently changed the guidelines, have the insurance companies caught up with that yet?
Not yet.
Do you think they will?
I think that was going to happen. I think that may take some time. So we are still following the old guidelines, where some patients, unfortunately, may fall under the new guidelines of qualifying for bariatric surgery, but they may not have the insurance coverage yet. But I'm hoping that will change with time, and that also will hopefully include, as I said, some of the newer operations that are being approved now that hopefully will get covered at some point.
Okay, so let's talk a little bit about the experienced team at the WVU Medicine Medical and Surgical Weight Loss Center. You've got a lot of experience.
We definitely have a great team here. I've been here myself for about 5 years, and I don't see myself leaving this place. It's an amazing place, to work at.
That's good. We're glad you're here.
It's so all the staff here that you got to work with have, training and have been working in taking care of patients with obesity for years. I have 2 partner surgeons, Dr. Novazoka and Dr. Lawrence DeBone. They're both excellent surgeons. They were trained at Duke. They've been doing bariatric surgery for years as well. So as surgeons, when you look at surgeons, all 3 of us have been fortunate to have great training, and we've been doing it for years. Between the 3 of us, we probably performed thousands of operations. So it's been, that's we also, by the way, maybe I haven't touched on that. We also do what we call revision bariatric operations, going back to the concept of chronicity of the disease. So meaning patients may have had bariatric surgery in the past, and they either have issues with the operation or have gained weight back. So we perform some of what redo operations, we'll call that revision.
Okay.
So we have experience in doing those too. So you have an excellent staff of surgeons. We have great dietitians that work with us. They've been working with patients with obesity for a year, specifically in our field. We work with great psychologists that provide significant support, and they are bariatric psychologists. They're trained to be bariatric psychologists. So they're not your average psychologists. They have special training in bariatric and obesity care. We work very closely with our medical weight loss providers. We have a great team, the WVU Medical Weight Loss Clinic here, and we refer patients back and forth, and we communicate, and we actually have a board meeting every month that we meet all of us together and discuss patient care. So, and of course we have great what we call mid-level providers, nurse practitioners, and PA that have been also doing this for years, as long as I've been here in this program. So we have a consistent team, I'll say. of course, that not to forget our schedulers that are going to help you get your appointments, and we have a navigator that helps you navigate the insurance claims and all those things. So you have a great experienced team here, and not to forget that we have a great endoscopist, Dr. Singh, who helps us with some of the bariatric endoscopy procedures and care. Yeah, so it's a great place to work, and it's a great place to have, if you're planning on having surgery, a great place to have. Yeah.
You'll be taken care of start to finish, and that's a long timeline.
As long as you commit for that long-term relationship with patients, then that's what we want to provide. And one last thing, COVID has facilitated for us using virtual care now, which was something we actually were trying to do for years before COVID.
And now
because
that
remember that West Virginia, we
yeah.
have many of our patients who live 3 or 4 hours away. And now we do a lot of things virtually. So we do our diet classes virtually. We do some information sessions virtually. We actually do some of the follow-up cares that are not, that you don't have to be physically there, like, some of the education. We do a lot of that virtually too. So many of our patients may opt to have surgery here, but they live far away. But we'll still take care of you. We'll still provide you help virtually, and maybe we'll cut down your traveling to once a year or something like that. But we'll provide you a lot of the care virtually too.
Good. Okay, so there's somebody watching this and they're saying, this sounds like a good idea. Where do they start? What's the first step?
Yeah, I think the first step, the easiest step, is always to just call our office, or you can go online and register for the information session. You're going to hear a lot of the things that I talked about today in the information session. You're going to see pictures and diagrams of the operation. So we dedicate an hour. We do it 3 times a month.
Okay.
It's usually Wednesday at 6 o'clock, 3 Wednesdays a month. We give the information session. It's free. You don't need to have insurance coverage. You don't need to pay anything. You just need to register and show up. And then
learn about
virtually. And learn about the operation, and learn and see if that will be something you're interested in. Once you find out that, I think I'm a suitable candidate, I think this is something I want to do, then you have to obviously look at your insurance coverage and contact our office. They will send you a health packet that you need to fill, and then we schedule you to see one of the surgeons. And once you see one of us, the program just kind of goes on autopilot. We do a lot of the things that you necessarily don't have to worry about scheduling. We'll schedule your diet classes, we'll schedule your clearances with the heart doctor, with the lung doctor. We'll do the blood work that needs to be done. So we kind of will guide you through the entire process, as long as you're willing to kind of come and do those, just make sure you show up to all your doctor's appointments, and then when the time is right, we do your surgery, and then after that, we continue with your follow-up. And again, that follow-up, as I said, mostly can be done in person or a lot of time virtually. So just to give you an example, we see patients after surgery, 2 weeks after surgery, we see them at 6 weeks after surgery, we see them at 3 months after surgery, we see them at 6 months after surgery, and then we see them at the 1 year mark, and then once a year afterward. So there's a lot of follow-up that we provide for them.
All right. Well, thank you so much.
You're
This
welcome.
was a lot of really good information, and now people know where to go when they want more information,
absolutely.
and we've started the conversation. So thank
absolutely.
you.
You're welcome.
Thank you
It's been
for joining
a pleasure.
us.
Yeah, you're welcome.
And that brings us to the end of this edition of Tuesday Talks. If you're looking for more information about weight loss surgery, visit wvumedicine.org/bariatrics. And join us next time on Tuesday Talks on January 10th, when we'll talk with Dr. Aaron Monceau about how to safely start an exercise program in the new year. I'm Mary Ravazio Menard, and on behalf of Dr. Abunnaja and everyone at WVU Medicine, thanks for joining us, and have a great day.